Assalamu alaikum. Today we will read AKP clinical case number 2, that is a 15-month-old with a cough and TB contact. In this case, we are going to talk about an important health issue that still affects many people around the world, that is tuberculosis or TB. As a pediatrician, when you see a child in your clinic with a cough that won't go away, is losing weight, and seems tired all the time, these symptoms could be signs of TB. TB is a disease that can affect anyone, especially children. Even though we have made a lot of progress in medicine, TB is still one of the leading causes of illnesses and death globally. As per WHO, in 2021, around 10 million new cases were reported, and every year 10 million people globally fall ill with TB. So, understanding TB is very important for us as future doctors because it mainly affects vulnerable groups, especially young children. In this case, we will cover several important points regarding TB. So let's start with simple explanation of what tuberculosis is and how it is spread. TB is a bacterial infection caused by Mycobacterium tuberculosis, which mostly affect the lungs but can spread to other parts of body. It is important to recognize TB early because it can lead to severe health complications if untreated. Okay, let's now look at the way how it is spread. When a person with active TB coughs or sneezes, tiny droplets containing the bacteria are released into the air. These droplets can be inhaled by individuals nearby, leading to infection. It is important to differentiate between two forms of TB, that are latent TB infection and active TB disease. In latent TB infection, bacteria are present but inactive, so people do not show symptoms and cannot spread the disease. However, they have a risk of progressing to active TB, particularly if their immune system is compromised. And in active TB disease, when the bacteria multiply, causing symptoms, and active TB is contagious. Now let's move to one of the most important part of diagnosing TB is recognizing the symptoms and signs. TB can sometimes be tricky to identify because its symptoms often develop slowly and can be mistaken for other illnesses. However, knowing what to look for can help us to catch it early, especially in children who may not show the typical signs. Uh, Suspect TB if the following symptoms last for more than 2 to 4 weeks: persistent cough, weight loss, lack of energy, fever and night sweats, enlarged lymph nodes. Other symptoms include headache, joint swelling, and abdominal distension. In infants, symptoms may be less obvious, but they are more susceptible to the disease. Physical signs that suggest TB include slow growth in children, fever, weight loss, swollen lymph nodes, in chest symptoms, difficulty breathing, chest pain, rare signs like joint swelling or abdominal distension. These signs and symptoms might seem vague at first, especially in infants, but when they persist and occur together, TB becomes a strong possibility that we need to consider. So always keep these in mind, especially in high-risk patients. Now that we understand what TB is and how it presents, let's focus on a critical aspect: who is most at risk. Tuberculosis doesn't affect everyone equally. Certain groups of people are much more vulnerable to developing TB. Identifying these high-risk groups is essential for early diagnosis and effective prevention. So, who exactly is at high risk for TB? Let's break it down into a few key categories. When people in contact with someone who has TB, people from countries with high TB rates, more than 150 cases per 100,000 people, children under 2 year old, people with weakened immune system. If a person falls into any of these categories, they should be screened for latent TB even if they don't show symptoms. These risk factors are important to keep in mind when you are assessing patients, as they guide us in identifying who need to be tested and treated early to prevent the spread of TB. Next step is confirming the diagnosis through appropriate investigations. See, TB can be challenging to diagnose because its symptoms can mimic other diseases. So we rely on a combination of tests to get a clear picture. What test? When TB is suspected, there are a variety of tests that can help confirm the diagnosis. For latent TB, a Mantox test or interferon gamma release assay. For active TB, chest X-ray to check for lung changes, sputum samples for testing TB bacteria. If a patient can't cough up sputum, a gastric aspirate or bronchoalveolar lavage can be used to get a sample. Depending on where the infection is, other tests may be used such as MRI or CT scan for brain or spine TB, ultrasound for abdominal TB, biopsies for lymph node, bones, or other affected tissues. These tests give us a clear picture of where the TB is in the body and whether it's active or latent. Remember, the key is to act quickly. Once we suspect TB, we don't wait for culture results to start the treatment, especially in high-risk patients or life-threatening cases. Once TB is diagnosed, starting the correct treatment is crucial to prevent complications and the spread of the infection. TB treatment is long-term and adherence is key to success. Let's go over the main aspect of TB treatment. Standard treatment for active TB is a 4-drug regime that lasts for 6 months. Initial phase of treatment lasts for 2 months, where 4 drugs are used: rifampicin, isoniazid, pyrazinamide, and ethambutol. After the first 2 months, we enter the continuation phase where we usually drop pyrazinamide and ethambutol, containing with just rifampicin and isoniazid for the remaining 4 months. The dosing of these drugs is based on the patient's weight, and it's important to calculate it accurately to avoid under or overdosing. During TB treatment are critical to ensure the patient is responding well to the medication and to catch any potential complications early. Here is how we approach it: by regular clinical reviews, monitoring for side effect, adherence monitoring, sputum and culture testing, HIV and hepatitis screening, end of treatment follow-up. Once treatment is completed, we don't just stop there. We monitor the patient for relapse or reactivation of TB. Treatment is completed, we don't just stop there. We monitor the patient for relapse or reactivation of the TB. A follow-up is usually done 3 months after completing treatment, and again after 12 months to make sure they remain TB-free. Referral is important when dealing with complicated infections like multi-drug resistant TB, HIV with severe immunosuppression, or infection with significant complications like CNS involvement or organ failure. So, infections requiring complex treatment regime or long-term follow-up. As we know, TB is contagious, so precautions are necessary. Patients with active lung TB should be isolated until they are no longer contagious. Close contact of the patient should be tested for TB and, if necessary, treated for latent TB. Public health measures, including vaccination, screening, and improving living conditions, are vital for preventing new cases and stopping outbreaks. As future pediatrician, your role in identifying TB early and managing patients according to latest guidelines will be essential in tackling this disease, especially with the rise of drug-resistant TB. Always work closely with your TB specialist team to provide comprehensive care for patients. Lastly, as TB continues to evolve with factors like drug resistance and co-infection with HIV, staying updated on the latest research and guidelines will be key to effectively managing this complex disease. Remember, timely diagnosis and appropriate treatment are crucial for reducing transmission and preventing complications, especially in young children. Continue monitoring and follow-up, ensure that the disease is fully treated and complications are avoided. Let's come to the case now. A 15-month-old boy has a 3-week history of cough. He was born in Slovakia and received a BCG vaccination at birth. His maternal grandfather, who lives with the family, is receiving treatment for smear-positive pulmonary tuberculosis. The boy's chest radiograph is normal and he has completed a week course of amoxicillin. A Mentox test is performed and when read at 72 hours, there is a wheel measuring 16 mm in diameter. So, of this case is a 15-month-old boy has a 3-week history of cough. He was born in Slovakia. Slovakia is a country in Central Europe, and where he received a BCG vaccination at birth. His maternal grandfather, who lives with the family, is receiving treatment for smear-positive pulmonary tuberculosis. This means the TB bacteria can be found in his sputum. Uh, the boy's chest radiograph is normal and he has completed a week course of amoxicillin. A Mentox test is performed and when read at 72 hours, there is a wheel measuring 16 mm in diameter. Even though the boy's chest X-ray came out normal and he finished a course of antibiotics, there is still concern because TB is contagious. The doctor gave him a Mentox test and after 72 hours the result was 16 mm swelling, which is considered a large reaction. We must know that what is Mentox test? A Mentox test, also known as tuberculin skin test, if result of 16 mm in diameter is considered positive in most cases, indicating that the individual has likely been exposed to Mycobacterium tuberculosis and, and may have a latent or active TB infection. The size threshold for a positive result depends on individual risk factor. More than 5 mm is positive in HIV-infected individuals, recent contact of people with TB, or immunocompromised individuals. More than 10 mm is positive in recent immigrants from high-prevalence countries, IV drug users, residents of high-risk settings, for example, prison or refugee camps. Children with more than 4 years are exposed to adult high-risk categories. When more than 15 mm is positive in individual with no known risk failure for TB. So here, in this case, given that the wheel is 16 mm, it would be classified as positive for TB regardless of the risk factors. This suggests the need for further investigations to determine if the person has latent TB infection or active TB disease. Additional tests such as chest X-ray, interferon gamma release assay, and a detailed clinical evaluation would follow to confirm the diagnosis and guide treatment. So here asked question number 1. Which investigation would be the most helpful at this point? Select one answer only. Options are A. Bronchoalveolar lavage, B. CT scan of chest, C. Galactomenon, D. Gastric washing, E. Interferon gamma release assay. The correct answer is D. Gastric washings. Let me explain why. Okay. In a child, it is very difficult to get sputum for testing. So doctors do gastric washings. This involves taking samples of stomach content because children often swallow their sputum. It's one of the best way to test for TB in young kids. The other options are not as useful at this stage. For example, bronchoalveolar lavage is a more invasive procedure that is not necessary right now, and a CT scan would not be helpful since the chest X-ray already normal. Galactomenon is a test used for fungal infection, not for TB. The IGRA test is a good test for TB but is not needed here because the Mentok test already gave us a strong result. Now the question number 2, which of the following statement about the BCG vaccine is correct? Select one answer only. So here correct answer is B. It is a live attenuated vaccine. Let's break it down. The BCG vaccine is made from a weakened form of a type of bacteria called Mycobacterium bovis, which is related to the bacteria causes TB. That's why we call it a live attenuated vaccine. Bacteria are alive but too weak to cause disease. So option number A is incorrect because one dose of BCG vaccine does not last forever. The protection can decrease over time, especially as people get older. C is wrong because BCG vaccine is actually better at protecting against more severe form of TB like TB meningitis or biliary TB rather than TB in the lungs. D is incorrect because the vaccine does not offer greater than 90% protection. In fact, its effectiveness can vary widely from around 60% to less, depending on the population and setting. E is also wrong. The BCG vaccine does not affect the IGRA test result. However, it can cause a positive Mentok test, but not the IGRA. The third question is, what is the best advice to give to parents of an infant with a 16 Mentok test? Select one answer only. So, after giving detailed explanation of Mentok test, I think everyone can give answer of it. It is very easy. So, E is the answer. Treatment will be required. Let me explain why. The Mentok test result shows a 16 reaction, which is quite large. In this case, the boy is living with someone who has active TB. So there is a high chance that this positive result means he is being infected with TB. Other options, A is incorrect. While we may do more tests to confirm active TB, the Mentok test combined with the exposure history strongly points to be infection, so we should start treatment. B is wrong because there is no sign that this test is related to an immune problem or HIV. The boy is reacting to TB exposure, not due to any immune deficiency. Is also wrong. A false positive is unlikely in this case. The size of Mentox reaction 16 suggests a real infection, and it's not just because the boy had the BCG vaccine as a baby. D is also incorrect because the reaction is too large to be due to BCG vaccine alone. Normally, a positive Mentox test result due to BCG would be much smaller. This is much more likely to be a true TB infection. Normally, a positive Mentok test result due to BCG would be much smaller. This is much more likely to be a true TB infection. So this case highlights the importance of early detection and management in children who may have been exposed to TB. Now some example from recall questions. A child about 12-year-old previously well live in a farm with his vegetarian alternative family. He complains of cough, fever that get worse over 1 week. On examination, there is left lung base dullness. X-ray shows massive left pleural effusion, and what they are asking, what is the causative organism? Options: Staph aureus, Mycoplasma, atypical Mycobacterium, TB, or Legionella. So, the scenario describes a 12-year-old child who lives on a farm presenting with cough, fever, respiratory distress, and massive left pleural effusion. Given the detail of the case, the most likely causative organism is tuberculosis. Here is why TB is the most likely diagnosis, because living on a farm, exposure to animals and farm environment can increase the risk of TB, especially zoonotic TB caused by Mycobacterium bovis from infected cattle. So, TB is a common cause of pleural effusion in children, especially in endemic areas or in individuals with risk factors for exposure. Other organisms are less likely fit with this scenario. Staph aureus more commonly causes empyema or abscess formation rather than isolated pleural effusion, and is often associated with more acute onset. Mycoplasma more commonly cause atypical pneumonia but rarely lead to massive pleural effusion. Atypical Mycobacterium usually associated with localized infection, not commonly causing massive pleural effusion. So that is also wrong. Legionella, it causes severe pneumonia. It's more commonly associated with water contamination and does not typically lead to massive pleural effusion in children. Here is another example from recall. Question is, a patient from Pakistan came with fever and cough for 1 month. He was given oral antibiotic without improvement. Then a chest X-ray was done. What is the next investigation to request? So here options are sputum um, culture and sensitivity, 3 early morning gastric wash, bronchoscopy with bronchoalveolar lavage, and Mantoux test. So in this recall, the patient has a fever and cough lasting for 1 month and is from Pakistan, a region with a high prevalence of tuberculosis. The lack of improvement after antibiotic raises suspicion for TB. The next step should focus on confirming this possible diagnosis. While sputum culture sensitivity useful in older children or adults who can expectorate, young children may not be able to produce enough sputum for reliable testing. Bronchoscopy with bronchoalveolar lavage is an invasive procedure and is not the first-line investigation unless sputum or gastric washing does not provide a diagnosis. Mentoc test: while the Mentoc test can suggest TB infection, but it does not differentiate between latent TB and active TB. A diagnostic sample is still needed. Answer is B. 3 early morning gastric wash is a reliable way to test for TB in children. These samples are sent for acid-fast bacilli staining, TB culture, and PCR. Early morning collections are most effective as secretions tend to accumulate overnight. Here is another question from the call paper. Question is, a boy from Bangladesh with headache received antibiotics and acyclovir, then deteriorating HP 4.5, CSF findings, protein 0.9, WCC 8, glucose slightly raised 2.6. this case, the boy is from Bangladesh, a high TB endemic area, presenting with headache, deterioration despite antibiotic and acyclovir. And the following CSF findings: protein 0.9, it's elevated, indicating possible inflammation or infection. Red cell count is low, suggestive of chronic infection, possibly TB. Glucose slightly low, consistent with TB meningitis. Hemoglobin 4.5 very low, likely indicating anemia, which can occur in chronic infection like TB. Likely diagnosis here is tuberculosis meningitis. Here is why: the patient geographic location or high risk area for TB raises concern for TB meningitis. Headache and progressive deterioration despite antibiotics and acyclovir, which are used for bacterial and viral infections, suggest the condition may not be bacterial or viral, but something more chronic like TB. CSF analysis: elevated protein and slightly reduced glucose levels are consistent with TB meningitis, which typically present with chronic symptoms and can be difficult to treat initially. So, if you want to add something, comment below, like and subscribe. Thank you.